Our next lecture is Parkinson's disease. Parkinson's disease is a disease of the basal ganglia characterized by slowing down in the initiation and execution of movement, increased muscle tonicity, tremor at rest, and gait disturbances. Parkinson's disease diagnosis increases with age. It affects about 2% of people over the age of 60. However, as many as 15% of those diagnosed with PD are actually younger than 50, and it is more common in men. The exact cause is going to be unknown. It could be a result of the environmental factors and the person's genetic makeup. So you want to look at family history, exposure to toxins, drug-induced Parkinsonisms. Specifically, drugs that can do that are haloperidol and metoclopramide, which is Reglan. And then other causes would be hydrocephalus, multiple sclerosis, previous stroke, tumors, Huntington's disease. When you think of Parkinson's, think about dopamine, or the lack of dopamine in the brain, rather. Dopamine is a neurotransmitter that's responsible for the control of your posture, support, and voluntary motion. The pathologic process involves degeneration of dopamine-producing neurons in the substantia nigra of the midbrain. They say when about 80% of those neurons are gone, that's when you see the manifestations associated with Parkinson's disease. This disrupts the dopamine acetylcholine balance in the basal ganglia. So that's kind of your pathophysiologic event. So this is showing neuronal activity in the substantia nigra of the brain in a normal person, and then on the right-hand side you can see in a person with Parkinson's disease that is significantly declined. Clinical manifestations. The onset of Parkinson's is gradual. It's usually insidious with an ongoing progression. The classic triad of Parkinson's, however, is going to be tremor. The tremor can be in the hand, diaphragm, tongue, lips. Rigidity, so that's increased resistance to passive motion. Rigidity in the muscles specifically. And bradykinesia, so that's a slowing of the movement. You can remember other acronyms. There's one TRAP, and that's going to be tremor, rigidity, akinesia, which is a little different than bradykinesia. That's the loss of or impairment of voluntary movement, and then postural instability. In the beginning stages, there could only be a mild tremor, slight limp, or a decreased arm swing. Think about when we walk, we naturally swing our arms, and that kind of helps us maintain our posture and our balance. But people in Parkinson's, they don't have that. In the later stages, they may have shuffling, propulsive gait, so they're constantly leaning forward with their arms flexed, and the loss of postural reflex. Some have slight speech changes. The tremor can be so minimal that initially only the patient notices it. It's actually more prominent at rest, and it's aggravated by increasing concentration. So if they're trying to stop that tremor from happening, it usually gets worse. It's described as pill rolling, and basically the thumb and the forefinger appear to move in a rotary fashion, and that's a classic exhibit of a tremor in a person with Parkinson's. Some people have a benign essential tremor that occurs during voluntary movement, and that can be misdiagnosed as Parkinson's disease. So it's important to understand what is happening when they have the tremor. Rigidity is increased resistance to passive motion when the limbs are moved through range of motion. It's typified by a jerky quality when the joint is moved. And there's this term called cogwheel rigidity, and that's because rigidity is similar to the intermittent catches in the movement of a cogwheel. That's also very typical. And when you hear the term cogwheel rigidity, people often think of Parkinson's disease. It's caused by sustained muscle contraction and consequently elicits the following: complaints of soreness, feeling tired and achy, pain in the head, upper body, spine, or legs. Bradykinesia is the slowing down in initiation and execution of movements. It could be evident in the loss of autonomic movements, so something as simple as blinking can be slower, or they could have like that blank stare. The swinging of their arms as they walk, the swallowing of saliva, so you're thinking aspiration risk right there, self-expression with facial movements. This resembles that classic appearance of a patient with PD, so they have that propulsive gait, their forward tilt to posture there. The tremor, I mean, you can't see it, but it's supposed to show a tremor in the hand. They have slow, monotonous, or slurred speech. There's really no emotion behind it. Blank facial expression, and then that short, shuffling gait. Non-motor manifestations are going to include depression, anxiety, fatigue, pain, constipation, sleep problems, and short-term memory loss. It also includes impotence, short-term memory impairment, possible sleep problems. A lot of them have nightmares, and they have difficulty staying asleep because of those nightmares. Um, because they can't sleep at night sometimes, they end up very drowsy during the day. Complications will increase as the disease progresses. Motor symptoms, for example, you could see more involuntary movements. There's increasing weakness, akinesia, neurologic problems such as dementia, neuropsychiatric problems such as depression, hallucinations. And then that bottom slide, dementia actually occurs in about 70% of patients with Parkinson's. Some other complications, dysphagia may result in malnutrition and aspiration. General debilitation could lead to pneumonia, UTIs, and skin breakdown. And then orthostasis can occur, which results in falls and injuries. There is no specific diagnostic test that's going to say, yes, this is Parkinson's disease, but essentially it's based on history and clinical features. A firm diagnosis can be made when at least two of the three classic characteristics are present, so you have your tremor, rigidity, bradykinesia. Ultimate confirmation, however, will be if the patient has a positive response to the anti-Parkinson's drugs. So there's a 67-year-old male. He presents to the clinic with a tremor in his hand that is interfering with his writing. He also complains of muscle aches and excessive drooling saliva that he cannot swallow. He doesn't remember when all this began, says it was a while ago. So right there, I'm already kind of thinking he's showing some kind of symptoms. His physical examination reveals rigidity in the limbs, shuffling gait, blank expression, and pill rolling in both of his hands. So he's diagnosed with Parkinson's disease. So which of the characteristics, the classic triad, is he exhibiting? So he has the pill rolling, there's a tremor, rigidity, so there's in the limbs, so there's rigidity, and then even that blank expression in the shuffling gait can resemble bradykinesia, the slowing of the initiation of movements. So he is anxious and worries that his tremors will never stop, but what can you tell him? I would say Parkinson's, it's progressive, it could get worse. However, there are ways that we can treat and manage the symptoms, even though we cannot cure the Parkinson's disease. So, like I just said, there is no cure for Parkinson's disease, but collaborative management is aimed at relieving the symptoms associated with Parkinson's. So, collaborative care. Our drug therapy is aimed at correcting the imbalances of the neurotransmitters within the CNS. Anti-Parkinson's drugs either A, enhance the release or release the supply of dopamine, and those are your dopaminergic drugs, or B, they antagonize or block the effects of overactive cholinergic neurons in the striatum, which are your anticholinergic drugs. Again, these drugs may provide symptom relief, such as relief of muscle rigidity, but it's not a cure. Levodopa with carbidopa is often the first line drug that's used. Levodopa is the precursor of dopamine and crosses the blood-brain barrier. It's converted in the basal ganglia to dopamine. So why do we have carbidopa? Well, carbidopa inhibits an enzyme that breaks down the levodopa in the periphery before it reaches the brain. Now, with this drug, patients can have on and off periods. Sometimes it works, sometimes it doesn't. It's not predictable. Furthermore, the use of carbidopa, levodopa, or Sinemet can wear off after a few years of therapy, and therefore, some initiate therapy with a dopamine receptor agonist instead. What these do is they directly stimulate dopamine receptors. Examples of these are ropinirole and pramipexole, which are also known as Requip and Maripex, if you've ever seen them. And then you may also see the use of MAOB inhibitors. MAOB in the brain degrades dopamine, so the inhibitors increase or maintain the levels of dopamine. The next two are COMT inhibitors, and what they do is they actually help block that enzyme just like carbidopa does. Blocks the enzyme in the periphery that breaks down levodopa, and that can prolong the effects of carbidopa levodopa in the brain. Other agents that can be used are anticholinergics, which will decrease the activity of acetylcholine. An example of that is benztropine or cogentin. You can see the use of antihistamines with anticholinergic or beta blockers, and those are useful to manage tremors. An example of that would be the use of loratadine and propanolol. And then there is the use of an antiviral agent, amantadine, which is also known as Sementrol, and the mechanism of that is unknown. Overall, the use of only one drug will be preferred for obvious reasons, but combination therapy is often required as the disease progresses. And furthermore, dopaminergic drugs can lead to a paradoxic intoxication where the patient actually has an aggravation of their symptoms. Some patients who are receiving any of these treatments experience episodes of hypomobility within 3 to 5 years. And hypomobility refers to the inability to rise from a chair, to stand or walk. That can be treated with apomorphine, and it has to be taken with an antiemetic drug, because apomorphine can cause extreme nausea and vomiting. Surgical therapy can be used. The procedures are usually aimed at relieving the symptoms, and it's usually only used in patients who are unresponsive to drug therapy or who have developed severe motor complications. One example is going to be ablation surgery. It's been used widely for about 50 years now to treat patients with Parkinson's. There is now the use of a DBS, but what ablation surgery is it involves stereotactic destruction of areas in the thalamus and global pallidus. And then the DBS, or deep brain stimulator, involves placing an electrode in the thalamus or global pallidus. It's connected to a generator placed in the patient's upper chest. The device is programmed to deliver specific current or targeted brain location. It can be adjusted to control symptoms, and it can be removed. And basically what the DBS does is it decreases tremors, it improves motor function, and it decreases medication usage. And this is pretty cool, but it's in the experimental stages. They have successfully used transplantation of fetal neural tissue in the basal ganglia to help provide and support dopamine producing cells. So nutritional therapy. Malnutrition and constipation are serious consequences. Patients with dysphagia and bradykinesia need food that is easily chewed and swallowed. They also need adequate roughage to prevent constipation. So, what we can do to help them is cut their food into bite sized pieces, provide several small meals, and that should help prevent fatigue. Provide ample time to avoid frustration. Remember, with their tremor, they might have a hard time, scooping things or lifting things. So we really need to give them as much time as we can. And then we have to keep in mind levodopa can be impaired by protein and by vitamin B6 ingestion. It doesn't mean that they can't have protein and that they can't have anything with vitamin B6. It's just we have to be mindful that we're not overdoing it. So, with our patient, what emotional issues might they have? Um, I think they would have a variety of emotional issues, possibly frustration, anger, depression. What can you tell him about his treatment options? Well, there's a variety of them as we just went over. We'll select the one that's going to work best for you. There's also, the potential surgical treatment or the use of a deep brain stimulator. And what monitoring should be done on him, considering the manifestations of the disease. We should monitor his swallowing ability, we should monitor his mobility and his overall safety. Assessment wise, we want to know if they had health history of any CNS trauma, cerebrovascular disease like stroke, exposure to metals and CO2, any history of encephalitis. We want to know if they're on any of these medications because these medications, well, most of them can slow the activity of the nervous system. Some of them can speed it up. So we really need to be careful about the balance there, especially if we're adding in dopaminergic drugs or anticholinergic drugs to help the patient. Health history wise, again, we want to know, do they have any fatigue, excessive salivation, dysphagia, weight loss, constipation, incontinence? Furthermore, we want to know, do they have any difficulty initiating movements, any history of falls, loss of dexterity, any diffuse pain in their head, shoulders, neck, back, legs, and hips because of rigidity, insomnia, depression, any mood swings? When we assess them, we want to look at their face. Do they have that blank face? Do they have that infrequent bleaking? Do they exhibit seborrhea, which is actually pretty common in these patients? Those are scaly, patchy redness on their skin. Do they have any dandruff? Because their skin is often very dry. Any ankle edema or postural hypotension? We're going to look for those classic symptoms like the tremor at rest or the pill rolling tremor in their fingers. Do they have poor coordination, subtle dementia? We want to know if they show that cogwheel rigidity, where their movements, they often show that jerk-like movement or stopping of movement. Any dysarthria, bradykinesia, contractures, stooped posture, and shuffling gait. Some of our common nursing diagnoses we can use: impaired physical mobility, imbalanced nutrition, usually less than the body requirements, impaired swallowing, and impaired verbal communication. Planning wise, we want to maximize their neurologic function. We want to maintain independence in their activities of daily living for as long as possible. And we want to optimize their psychosocial well being. Now, because Parkinson's is a degenerative disorder, there is no cure. Usually, there's no exacerbations. Their symptoms are pretty progressive and chronic. We want to focus our teaching then on the maintenance of their health, the encouragement of their independence, and the avoidance of complications such as falls. So we need to promote physical exercise with them in a well-balanced diet. We want to limit the consequences from decreased mobility, such as pressure ulcer development. There are specific exercises that they can do to strengthen their muscles involved with speaking and swallowing, and we can consult and work with speech pathologists or speech therapists to handle that. Problems associated with their lack of voluntary movement can be alleviated by having them consciously think about stepping over a line on the floor, making sure they lift their toes when stepping, giving them cues and initiations of movement. We can teach them to get out of the chair by using their arms and placing the back legs on small blocks. Make sure that they remove rugs and excess furniture, especially if they're home. Um, Simplify their clothing from buttons and hooks. So think about their tremor. If they're wearing a button-up shirt and they have that pill rolling tremor, how are they going to be able to successfully unbutton or rebutton their shirt? Use an elevated toilet seat. Use an ottoman to elevate their legs and prevent any buildup of ankle edema. We want to assist the patients as they make adjustments to their lifestyle and accommodate their symptoms. The caregivers can also experience stress associated with the disease progression, so we have to keep them in mind. So what changes could MJ and his wife make to the house? They're going to need to remove the clutter from around the house, maybe look at their rugs, maybe install specific equipment in their bathrooms, make sure they have railings, maybe add, a bed downstairs for him to sleep in so he's not walking up and down the stairs. Different things like that. What other teachings could you do? Nutritional teaching would be huge. Preventing mobility issues like pressure ulcers. So, trying to maintain physical activity. How might the disease progress? Well, like I said, it's not really characterized by like a relapse remission like multiple sclerosis. It's more characterized by a progression of symptoms. They do get worse. So we do want the wife especially to be aware of that. So now his wife tells you she thinks he has dementia. And when you're working with a patient who has cognitive impairment, what modifications to your teaching can you make to facilitate understanding? What I do is keep it short, keep it simple, make it something that they can understand. Don't use big words. Do frequently remind them of the things you taught them, and definitely have a caregiver present like his wife. Our expected outcome is that our patients will be able to perform physical exercise to deter muscle atrophy and joint contractures, that they'll use devices appropriately for ambulation and mobility, and that they'll maintain nutritional intake adequate for metabolic needs. Furthermore, we want them to experience safe passage of liquids and/or solids from the mouth to the stomach, and we want to use methods of communication that meet the needs for interaction with others.